we are going to launch a new version of our mobile application. And whenever we do clinical practice, we are often challenged with scenarios where we don't remember everything, we don't understand the approach, and we don't understand the figures. We want to use some calculator, and it's very difficult to do it on a day-to-day basis. Now, I always thought that when you are managing a case, like a challenging case comes to you, let's say of a persistent hyperinsulinism, the conventional approach is that you go back to the books, start reading from there, try to get back, and then decide how to manage. The problem of this approach is that most of the time you'll start off with pathophysiology, then you will go on to what are the causes, then you will go to evaluation. So by the time you reach to the management, it becomes difficult. So what we have been trying to do and what we have been thinking for over a decade is to bring those algorithms that have been developed into real practice, which make it very easy and to do it on a point of care fashion. These are relevant predominantly for people who have less exposure in pediatric endocrinology, but also helpful for everybody. So if you're using it and you're sure that this is the way it should go in a precise manner, the applications will help out. So we started around 5 years ago, and today we're going to start off with many new formats of these interpreters, which will allow us immediate evaluation and management on that perspective. So over the next 2 hours or so, we are going to really highlight how these solutions can help out in terms of our day-to-day pediatric endocrine care. Now, why we started thinking of developing these tools was this case, whom I managed when I came back immediately, maybe 15, 16 years ago, was this 7-year-old boy with short stature who came to us at a time when nothing could be done, in that the bones were fused. Now, this is not unusual. Still, 10 to 15% children come to us at a very late stage. What was unfortunate in this case was that he had all the features of celiac disease. He was TTG positive, but unfortunately, because of the severe anemia he had, that was maybe around 5 to 6 years ago, he was evaluated by a pediatrician who advised blood transfusion, which culminated into HIV/AIDS. So a reversible thing, a very simple thing like celiac disease turned out to be in a very adverse scenario. And that made us think what could have gone wrong and how could we have improved in that regards. So the most important thing in terms of the improvement of care of any particular individual with a health disorder is awareness. If the patient is aware at the right time when to go to the doctor, if the doctor is aware what things to order, how to evaluate, we can prevent most of the things. Accessibility to specialists is number two. Affordability is last. So often people think of pediatric endocrinology that you need very expensive investigations in a very complicated scenario, which is not true. If you do it at the right time, you can identify in that regards. Now, how do we really have a true evidence-based clinical practice? For that, there are multiple things that we need to implement. Of course, there are a large amount of books which are available. You have to put all that knowledge back into clinical practice. This involves ordering rational tests, especially in resource-poor settings where you can't just order every test all the time. You have to use that in terms of algorithms. You have to understand about the various drugs, the interaction, how to use, what dose to use, and then finally you have to take everything up to make that. So the process of a rational management of a child with endocrine disorders, of any child, requires a comprehensive combination of diagnostic, therapeutics, approach, management. All this perspective is important. So we tried to build up resources which will help us in terms of overall improvement of pediatric endocrine care initially in the country and then beyond that. So we started with workshops. So we have conducted over 200 workshops across the country. But that itself is a very tedious process, and the retention of people is not a long time. So they will forget. Maybe once you do a workshop, 1 week later, everything is gone because they're not implementing in the clinical practice. We started with practical courses. So 15 courses have been done in the country, but they are extremely resource intensive. You would need a lot of time, energy, money, everything. So it's not easily feasible. We started with our YouTube program, which provides a lot of free channels. So this is also there. We started an on-site fellowship. So till now, we have 14 fellows who have joined. So this is something. But then again, the reach is limited. To take it forward, we started with our MedEClasses, which was our online portal, which takes it beyond the routine classroom to beyond so that people can use that knowledge and understand in a systematic fashion, brought up the textbooks. But then at the end of it, what we realize is that unless and until we have something in the hands of a physician at the time of management, they would not be able to implement all this knowledge, because knowledge is there. Unless you see it day in and out, then it's in your reflex. Otherwise, you will forget. So then we thought 5 years ago to develop a mobile application, which at that time was a unique way of managing cases, and still now it is one of the very rare ones in that perspective. So as I said, we have done a lot of pediatrician initiatives across India and abroad, including a lot of workshops, practical courses, advanced courses in that perspective. Our e-learning portal has got huge number of videos and a lot of watch time. We have organized learning, which is a validated program at learning.growsociety.in, which offers courses for pediatric endocrinology to various aspects, starting from the fellowship program to small fragmented courses in that regards. And these have been accessed from people across the globe, which has culminated in that. We have got 3 publications, both basic, advanced, and protocols, which form the basis of many of these applications. So all these algorithms that we use now are largely based upon many guidelines plus clinical experience, and many of these are already published in these books. So we have used that to translate these books right away for clinical management. So the MedEClasses Endocrinology was the app which was basically released around 5 years ago. It is the most downloaded pediatric endocrinology app, or an endocrinology app, so to speak, with 10,000 installs. There are multiple places where it has been presented, multiple awards have been given. There are publications also which have come out from there. Now, the crux of this app is to try to translate what knowledge is in terms of clinical practice. So the most important ones which started off were approach pathways. Now, how these approach pathways were working was like these flowcharts. So there will be questions which people will answer, and based upon those question answer, we would be able to achieve the diagnosis in that perspective. And this is how you will read. So based upon your results, the next question will come up, and then subsequent to that, a final diagnosis will come up. So this was a stepwise approach. It simplified the algorithm. Now, if you have, let's say, algorithm pasted in front of you also, it may be more difficult, but if you get precise answers, it made it much easier in that regard. So there are covering entire parts of pediatric endocrinology in the approach pathway. There are management pathways similarly, because many of these scenarios, like if you think of increased insulin effect, how do you decide which workup to do, what to do? So we developed these management pathways. This allows implementation of algorithmic approaches and management on a clinical basis. So it gives you a personalized guidance. Now, the problem with these pathways is, which I don't think it's a problem, it's part of their way they have been developed, is that it will take a bit more time and you will have to put inputs every time. This is an advantage also, because then you can get a much more detailed picture of the clinical scenario. But often in this day and age, we want instantaneous results, that we want immediately that you input the data and you get the output. So for that, what we tried to develop was interpreters. And one of these interpreters is like thyroid interpreter, which Dr. Vibha will talk a bit more, in which what you do is that you just enter your analysis, and based upon that, you will get the diagnosis as to what you're dealing with. We have now largely taken forward a number of interpreters, and this time which we are going to launch is interpreters which are holistic approaches for complete electrolyte disorders in a single interpreter, hypoglycemia, calcium, and these interpreters have become, they are instantaneously more helpful because they give immediate results. But we need to remember is that because they are based upon one-time input, they may not be as encompassing as compared to a approach pathway. So often if somebody uses that, like here what it says, follow approach pathway as well. So this is for the initial guidance, and then you can go ahead and use the approach pathway from that perspective. Now, of course, when you say that you do a particular test, let's say a AMH test, you need to understand when to do the test, how to do the test. So you don't want to go back to the book and open it up. We have a full diagnostic section which provides what is the timing, what is the sample type, what is the reference range, and everything is available within the app. So within a single app, you've got all the information. Similarly, if you want to prescribe a drug, there is a therapeutic section which really provides the detailed information. So all the drugs which are used in pediatric endocrinology are there, and we give all the adverse effects, interaction, and all those parts in that regards. Many times in pediatric endocrinology and other aspects, you want instantaneous calculation of things. And this is something which we have provided. And this is not only simple calculator, it is also helping us in scoring system. So like external masculinization score, often people will forget. Those who are not using it regularly won't remember. So here you will get what exactly you have to input and you will get the result. Similarly, bone age, this was a Achilles heel for pediatricians. So this was a major development which we did in terms of developing a bone age tool which uses only 5 sites to provide an accurate estimation of bone age, which can be done rapidly even via a non-expert. So this is something which has been used now across the globe. This has been published and validated, and we are going to make it even more simpler, hopefully soon. And things like Ferriman-Gallwey score, which may not be possible for the patient to examine right in the clinic, we can ask the patient to self-rate and they will give you a picture. So this is going to help you provide an objective estimate of clinical parameters. Now, many people say, okay, we now have a pathway, we now have interpreter, but we want to learn a lot. Now, what we have done is that entire knowledge bank, which is there in our website, is provided here as well. So if you want to read a particular thing without the figures, otherwise the load will become too big. The app will become a lot of GBs there. You have got all the textual information you can read about any particular condition. So entire knowledge pathway is there, and you can also test your knowledge using the mobile pathways in which questions are there, which scenarios can be used. So what we have tried to do is to bridge all the things, including diagnostics, therapeutics, approach, analytics, to get the clinical management based upon the latest state-of-the-art guidelines from that perspective. And this is something which we wanted to do. So a lot of awards have been given. So in 2019, we had the presentation as far as the bone age interpreter is concerned. Dr. Riddhi had presented that and won 2 awards, one from the IAP Research Conference and the Indian Society of Pediatric Endocrinology in 2019. Dr. Sayan won the award and the West Bengal IAP in 2022 regarding puberty interpreter. Then we had a good presentation on bone age in the novel tool used by Dr. Naveen at the Asia Pacific Pediatric Endocrine Society conference in Seoul. Dr. Vibha has been presenting many of these ones, including in the American Thyroid Association, including the thyroid interpreter. Then we had Dr. Alapan, who presented the diabetes interpreter at the Asia Pacific conference. Dr. Dhwani, who won the DSD interpreter. So a lot of publications have come out from there, including the growth chart, the DKA management, and the bone age assessment, and many more are on the way. So what we're going to do today is to try to cover a wide variety of pediatric endocrinology and how our tools can help us. Talk about diabetic ketoacidosis. There are multiple aspects of treatment, but the first treatment, of course, is in the form of fluid. And as soon as we give fluid, we would be able to decrease the counter-regulatory hormones and dilute the overall plasma to decrease the blood glucose by around 100 to 200 milligram per DL in the first hour. Then we have to start insulin to correct for in terms of the correction of diabetic ketoacidosis, correction of other parameters. So these are the 2 major things to look at. But giving too much insulin is going to be hazardous. It is going to cause hypokalemia. Giving too much fluid is going to cause cerebral edema. So we need to be cautious about in that perspective. So both of them have to be monitored. If you give too much fluid, as I said, cerebral edema and hyperchloremic metabolic acidosis, too much insulin will cause hypokalemia. There is a phase-wise management of DKA, and SPAD has laid down wonderful guidelines, which all of us should follow, in which we have got the first phase in which we just give fluid, the second phase in which we give the fluid over 48 hours and add insulin, and finally, we add dextrose when the blood sugar becomes less than 300. Soda bicarbonate should be avoided, and beware of cerebral edema is something which is important. So in the initial 24 to 48 hours, we want to give maintenance and deficit using the standard formula, and we correct these aspects over a 48-hour period. Do not give too much fluid and always deduct the boluses which have been given in that perspective. And we can think of alternate solutions which can be of help in that regards. Monitor for sensorium, hydration status, and urine output, because oliguria and renal failure is an important problem here. Sodium levels should remain stable, potassium should be normal, and acidosis and ketones should improve over time. If the serum potassium is less than 3.5 right at diagnosis, we have to add potassium in the fluid, defer insulin, and think of potassium infusion. If it's between 3.5 to 5.5 or 6, we have to add potassium in the fluid, and more than 5.5, avoid in that regards. If a child develops polyuria, myopathy, think about a possibility of hypokalemia. intervention is potassium infusion, reduce insulin dose, and consider magnesium, particularly if somebody is malnourished and there is celiac disease in that perspective. Once the blood sugar becomes less than 300 at 5% dextrose, becomes less than 200 at 10% dextrose, because we will take more time for acidosis to resolve. Bicarbonate should not be given, and if there is persisting acidosis, first exclude whether DKA has resolved or not, then exclude your hyperchloremic metabolic acidosis along with lactic acidosis. So anion gap or a chloride load will give you the correct diagnosis in that perspective. If it's a hyperchloremic metabolic acidosis, which is very common on treatment, it will improve. Do not continue your insulin in that perspective. Bicarbonate causes a lot of problems like CNS acidosis, hypokalemia, and lactic acidosis. It should be avoided unless there is life-threatening hyperkalemia, hemodynamic instability, and give it as an infusion in that regards. Be wary of phosphorus. If you have a very severe decay, start with potassium phosphate as half, and if there is altered sensorium, myopathy, or rhabdomyolysis, think of a possibility of hypophosphatemia in that perspective. So as discussed, if you give too little fluid, you will have dehydration. Too much fluid, you will have cerebral edema. If you give too little insulin, you will take more time to settle. But if you give too much insulin, you will have hypokalemia. So any day, I would prefer somebody to stay in the ICU dehydrated for some more time than to die because of hypokalemia or cerebral edema. So this is what we want to do, is to go slow. Now, this is all theory, but when we actually looked into our own data as to what our people were doing, the intensive care physicians, they do in the immediate first hour of treatment, we found a lot of errors despite so many classes, despite a written protocol. There were around 82% records had an error. And these errors could be that bolus was not given properly, the insulin dose was wrong, sometimes dextrose was not initiated, potassium was not initiated. And these errors could have prevented 32% of hypoglycemia, 58% of hypokalemia, and 34% of dehydration. So despite a good amount of exposure, a lot of errors happen. So what will happen in situations wherein the resources are not available? And this triggered us to development of our diabetic ketoacidosis guidelines, which basically uses the tools and the guidelines largely from ISPAD to implement it on a personalized basis. So I'll now invite Dr. Alapan to start off with the case scenario and how does it go forward from there.
Thank you, sir. So I'll start with a case. A 10-year-old child presented with blood sugar of high blood sugar level 540, weight of 30 kg. She has severe dehydration with a pH of 6.9 and dehydration almost 10%. Pace excess was -18.
So how will you like to manage this child? Will you manage in the ICU or will you manage in the ward?
In this perspective, this child is having a severe decay. So we'd like to manage this child in ICU, obviously.
And would you like to, how much fluid will you like to give, correct, or how much time?
We'll like to go for a slow correction in this scenario because the acidosis is severe. So too much early correction would cause increased risk of cerebral edema in this scenario.
Okay. So how will you go about? So let's go.
So initially, okay. So
if we go on to put all the data, so what we have discussed with Alapan, now what the app tells you is that whether this child has decay or not. So decay is there. Now you talked about initial bolus. So initial bolus should be there.
Yes.
What about the potassium? So 5.8 to 6, we can think of adding potassium. Now some guidelines say 5.5, some say 6. So we can vary, but this you need to give a potassium. The correction is at least over 48 hours, as you said. If there are features of cerebral edema and diagnosis, you may consider over 72 hours. Start insulin and it gives what to monitor. So this is exactly the ISPAD protocol we have come out here, which will give you how to go forward. Carry forward.
Moving on to after 8 hours of the monitoring, the blood sugar came down to 180 from 540 and the base excess was also reducing. It is -18 to -12.
So what do you think should be done here?
So
the child is better, his sugars are better, let's stop insulin?
No, in this scenario, we have to remember that once the acidosis doesn't correct, we should not stop insulin in that infusion, and the blood glucose level will not be a cutoff for stopping the insulin infusion.
So this is a very common mistake that people decrease the insulin or stop the insulin. Let's say how the app works. Now, this is the second scenario in terms, no. Okay, just one second. So this scenario basically, you go forward. So this scenario basically we put all the data, and what it tells you based upon this is now that you should add dextrose. There is inadequate urine output. So it's looking at multiple parameters. The urine output is less, it will say check for renal failure. You want how much urine output usually? Minimum.
More than 1 ml per kg.
So 1 ml per kg per hour. And then you have to think of cellular edema. So if the corrected sodium falls, watch for cellular edema. So there are multiple small triggers which are there which may miss out if you don't put all the data, which the app will be able to identify that in that regards. Now at 20 hours, now the child is much better. His sugar is 212 and base X is still minus 12. So what do you think is happening here?
So we have to see whether this acidosis is due to the ketoacidosis or whether it is due to the hyperchloremic metabolic acidosis. It could be because we have given so much NaCl in that scenario. That could be one possibility here.
So how will you distinguish the two?
We'll look for the chloride load in that
chloride load and gap lactate, they will help you out. Now the difference between the previous scenario, 8 hours I don't expect acidosis to go up. 20 hours it should go up. So here I want to be more proactive, otherwise we'll continue to treat. So let's say what the app does here, you put all the data that is there and it says now probably don't worry about this minus 12, ketoacidosis is resolved. Then you start thinking of it also gives you how much insulin dose is to be suggested based upon the DKA and the child being pubertal, pre-pubertal, you will get. Now, more of people think about that if you have technology, it is going to replace the physician. It's not going to. Technology is there to assist the physician. And if we do not move with the technology, then we may be left behind. So what our aim is, definitely not to replace any clinician. It's just to support, aid, guide. Sometimes you're not sure about what the guidelines would suggest, what level is appropriate, how to do those calculations. The app is meant to help out. And it also specifically tells you where you need to seek a specialist opinion as well. So this is mainly to assist people at all levels. And our studies, if you look at the interpreters for DSD, for diabetes, it may also be helpful not only for the training pediatricians or the pediatricians, but even for endocrinologists and pediatric endocrinologists. So just to ensure that you have a continuous growth, you can just have a look as to what it is suggesting. And then final diagnosis treatment will depend upon, of course, the overall clinical scenario. So we encourage all of you to go and have a look at our MedEClasses Endocrinology app. It's available both on Android and iOS store. In the first 7 days, it's free for use for everybody. So you can have a look at it. And then it's available for subscription at a nominal fees in terms of the clinical perspective.